58-year-old female who's been presenting to our clinic with lower back pain. He has an increasing motor weakness, hyperexflexia, and a radiculopathy of the lower limbs. He's been around the clinic for a couple of years. He had a prior cardiac syndrome, on which he received a laminectomy and a fusion of the lumbar spine. And he also has an excessive medical history. He also presented with a subacute L2 fracture. At that time, we opted for a non-medical treatment. Due to his medical complications, he hasn't been cleared for surgery by multiple departments, and in the later course, he has also had a severe respiratory failure with an RDS and a need for long-term ventilation. So when all of this seeded, he presented to us again, as I said, with this increasing lower back pain and motor weakness. On the right side, you can just see about on the left side being predominant the weakness and hyperexflexia. So this is his CT scan upon 1 year prior. So you can see the instrumentation with good healing of the intervertebral body fusions. But obviously there is a fracture and a possible screw loosening at L2 again at that time. He wasn't cleared for surgery. He had major medical issues, so we opted together with him for a non-surgical treatment. So then I'd like to show you the current CT scan. You can see that he has developed a severe deformity, kyphoscoliosis of the thoracolumbar region, massive erosion of L1, and also now loosening or more clear loosening of the L2 screws, resulting in a stenosis of the spinal canal at the upper lumbar region, as well as bilateral neural foraminal narrowing. We also performed a MRI scan, but the imaging didn't have very good quality due to the implant's presence. That is why I didn't show it at this time. So to summarize, we have a 58-year-old patient with worsening of his symptoms, especially lower back pain, but also increasing motor weaknesses. He has a super high risk profile for any types of complication. In the past, he had a severe medical complications, including an RDS on top of his chronic COPD with need for home oxygen supply. The imaging shows that chronic adjacent segment disease with now development of kyphoscoliosis of the thoracolumbar region with a massive L1 erosion. I'd like to start off with this discussion.
So let me just pipe in. Thank you, Julius. Can you hear me okay?
Yes, we can hear you fine.
Yeah. So first of all, welcome to our guest professor, Dr. Peter Passias. He's professor of neurosurgery and orthopedic surgery from Duke, and he is an amazing colleague. We'll do a formal introduction later, but can't ask for a more qualified colleague than him. If you wonder about my outfit, I'm in Thailand. I'm at the Global Spine Congress 2024, and our team, many of our team members are sitting right behind me here. But I wanted to see this meeting and see these cases and the presentation of Dr. Passias on spinal deformities. And I don't know what's going on, Peter. Is it just my impression that the world of spine care is just falling apart more and more? We're having more sick people with terrible spines. What's going on? Is this ongoing spine disease something that's borne out due to the growing ill health of our patients, or is there reverse causality? What's happening that we're having more and more sick people with these really bad spines? Did we cause that? That's the obviously ultimate question, by doing unnecessary or too aggressive spine fusion surgeries.
Yeah, first of all, thank you, everyone, for the invitation, and in particular, Jens, thank you for that very kind introduction. To cut to the chase, I agree wholeheartedly with what you're saying, and I think there's a few themes that are contributing to this. I think certainly there's population trends, we're increasing the life expectancy, but we're not increasing necessarily the health expectancy during your lifespan, which is something that's a population health issue. But from a spine-specific perspective, I think some of this is we're getting what you paid for. We did a lot of surgery over the last few decades, in conjunction with us starting to learn and understand spinal realignment techniques. There's been so much technology that's hit our field, and a lot of it's trial and error. And I think we're, in some respect, your point exactly right on, we're dealing with iatrogenic related issues, such as this case, where we start off with one problem, and then a few years later, we're dealing with a bigger problem. So, I think those are the two competing themes that are leading to the growth of complex spine surgery and, the need for us to tackle these complicated cases.
So yeah, great circumspect overview. So now the practical question that I have right off the bat is, all things being equal, with a fusion that kind of, if I saw it right, Dr. Gerstmeier, started somewhere around L2 and ended at L5 over short or long, are those just doomed to fail and leaving the L5S1 junction for a long while? We thought mechanically that we can offload the L1-2 junction. Is there something else going on, like a sacralization that was missed or so? So does preserving the 5-1 junction actually help diminish the offloading or increase the stress transfer at the upper lumbar spine?
Yeah. So I think, so the first point I would say is we have to look at our patients, almost like we look at our deformity patients, almost like we look at our tumor patients, where what is the functional achievement that we can obtain with these surgeries? What are they starting out with? What's the maximum that we can achieve? And then also in a case like this, what is the projected even life expectancy with an individual that is so disease burdened, by other comorbidities? I'm very reticent in the setting of a deformity, and I know this is a debate, at every meeting, the value of fractional curve corrections, selective fusions for partial curve corrections, and certainly in frail individuals, that's something that is a real consideration with a lot of our combined lateral and posterior techniques, our single position. And I've been a proponent of that in some individuals, that can't tolerate full corrections. But, this is a case where it's come back to bite us. And, I think it's more than just the fact that a selective fusion was performed. I didn't see the x-rays before and currently, it didn't seem to me like at the time of treatment they had such a significant deformity. But effectively, the treatment failed. There was a fracture, and at least the UIV, there was erosion, probably partially due to instability. So I think probably the levels were chosen incorrectly in retrospect on this case, and we needed a more stable, at least UIV, to avert this kyphoscoliosis that's occurring at the junction. The other issue with this case is this is a patient who presented with cauda equina syndrome. So, I don't want to be too critical of what was done at the time of treatment, but that also, their persistent and progressive weakness puts them at risk for abnormal biomechanical patterns in their gait and in their lumbopelvic mechanisms. So that also stresses this construct, to a very severe degree. So if this patient, at the time of treatment, neurologically, really wanted to help them, decompress them, and without knowing everything, I don't judge that. But this patient's a high risk for failure, and I think that's why we're ending up with this particular problem.
My final question, then I'll shut up with my questions and have my colleagues, Rod and Dr. Abdul-Jabbar, take it forward, is the soft tissue destruction at this junction zone. So this seems to a particularly aggressive kind of a process. There's radiolucency, there's some sclerosis. It's not your usual kind of just degeneration. It seems like a chondrolysis that then has taken over into the vertebra. So this is a aggressive inflammatory, destructive inflammatory process. Any thoughts on why one patient develops osteophytosis and the other one develops this kind of an angry chondrolysis with reactive tissue changes? Goes almost like into an aseptic infection picture.
Yeah, absolutely. I think, as I alluded to earlier, certainly I would want to make sure that this is there's nothing going on from a microorganism perspective. But outside of that, I think this is an issue where some instability at the UIB level, with perhaps screw toggling, frailty and osteoporosis at that level, kind of had a progressive problem that resulted in this osteolysis. I think I would want to know a little bit about the timing of that. It seems like it was not present right after the initial surgery, and we're dealing with this problem years after. Certainly some of the biologics that we use can predispose patients to this. And then we have the whole other concept of indolent subclinical infections and whether or not these contribute to this. But in my mind, I don't think we're going to find an overt infection, whether or not there's a contribution from a subclinical perspective. I don't necessarily think that will dictate care. I would certainly take cultures at the time of the surgery, but I really think this is an instability issue in the setting of a very poor bone quality, where there's progressive collapse in that area of instability.
So Peter, those are great comments. And actually, this is a patient who he almost developed like a Charcot kind of arthropathy. And Julius, that was a great presentation. The one thing I think that's hard to get from the medical records, Julius, is this guy was wheelchair bound. That's why I wanted to show this case. I mean, I think the initial surgery, that was done, no matter what he was probably going to be doomed to fail. I think you saw his comorbidities, got COPD. He's, I think, only 50. He was in his late 50s. And the trouble with this case, and this is why I wanted to talk about it, is that I think Jens pointed out is, on a patient like this, you try to do something smaller, and then you get something like this, that he develops, I think he developed like 3-4 years later. And he's such a high risk medical patient. I think we actually had a very difficult time getting him to be cleared for surgery just because of his pulmonary PFTs were so bad. And he's at high risk for having, complications, obviously, after surgery. So the question is, what do you do next? How high do you go? And then what do you do at L5S1?
Yeah, I mean, I think.
What are your thoughts, Peter?
Yeah, great points, Rod. I think, this is a type of patient where, and I'm going to include some of this in my talk, where we have these idealistic goals, of realignment and having a durable correction for patients that are going to have, at minimum 5 to 10 year survival to make it worth our while. This is a patient, in my mind, I would have a very heightened risk for that patient not being able to tolerate a big surgery. And this patient has a spine complication, but if this patient has potentially pulmonary or further complication, that's not consistent with getting the patient out of the hospital or individual capacity of caregiving, then I think, that would make this patient even worse, even if we have a perfectly looking spine. So this is the type of case I would involve, several departments in discussing this case. I wouldn't just go with my surgical plan. I would want to know the risk of this patient. I would certainly do a lot of calculations of what I thought their risk was. But my gut feeling is that this patient cannot tolerate, a full correction fusion, all the way up to the spine like they would typically need past the thoracolumbar junction. So if that is proven to be the case from a medical perspective, I think, perhaps we're entering the realm of a more temporizing procedure, where we're reconstructing that void in the column at L1, through some type of lateral support, and stabilization percutaneously with indirect decompression. Now, we haven't had a good look at the neurologic structures throughout the spinal column. I'm not sure, other than instability and dynamic compression at the conus level, I presume that's why they have progression. I don't think there's probably any direct high-grade compression other than that. So that would be my initial thought on this. Certainly, if the patient miraculously had, great medical situation and was doing well, with their medical treatments and optimization regimen, then I think there's some major issues with the alignment of this spine. The base of the spine, L4 to 1, the proportional distribution is clearly off. We would need to do some work at L5, S1. He has a history of RSD too, so I'm always hesitant on doing anteriors and retracting the sympathetics on patients with RSD. So they have a very large disc space. I think with just some low-grade osteotomies at L5, S1, we could avoid that. But the bulk of the correction here would have to be at that large L1 deficit. And I think in my hands, I think this is something that, through a minimal approach, I think we can reconstruct that probably through a single position, either lateral decubitus or even prone at this level, and get some type of structural support at that level and extend it up with really minimizing the blood loss and minimizing the operative time would be my two thoughts on that from a
And then
surgical.
Peter, would you do a TLIF at 5'1"?
Yeah, I think I could achieve in this patient what I need with a TLIF at 5'1". If this was a typical healthy patient, I think like an oblique ALIF while I'm doing the lateral is a good option. I think that would really extend the case if I'm going to do a lateral corpectomy and then an ALIF approach for 5'1". So those are good options, I think, in an ideal patient.
And then at 1-2, there's a pretty significant coronal deformity. Would you try to just fuse him in situ, or would you do an interbody there as well?
Yeah, I wouldn't fuse him in situ. I think he's unstable enough where, even just by instrumentation wise, you would get an acceptable realignment. But I think too big of a gap there to rely on posterior fixation, if he's going to have any type of longevity. So I would certainly do a lateral interbody at that level.
And pelvic screws as well, just to anchor everything, or?
Yeah. So I think, pelvic screws now, even if we have to minimize the operative burden, we can do with very minimalistic approaches, so I think if you do not stabilize and lock in your alignment with pelvic fixation, and someone like this who already has as you alluded to, a Charcot joint, he will get that same thing at the base of the spine, and he'll be in a position where we can't operate on him, presumably with his projections in a few years.
So Julius, do you want to go over what we did?
Yeah.
Okay, great.
So we opted for a long construct. The patient was optimized medically so that we actually can achieve this kind of operation. We did a TA to pelvis with interbodies on L1 and 2 and L5 and S1, and osteotomies at T10, 11, and 12. The patient did well after surgery. He had a short stay at the ICU postoperatively and was discharged to a rehabilitation facility 6 days postoperatively.
So Peter, we do a lot of these. I think you've seen our work on interdiscal osteotomies, where you can get a pretty significant, with a lot of these expandables that have come out. We try to get a pretty good reduction and then try to get the biggest implant that we can to fill the defect. And we can get pretty significant. I think you can kind of see that. These cages are getting a lot more. They get a lot of them have now. You can get lordosis, and you get almost 15 to 20 degrees per level. So that's
Are
what
these intraoperative photos, Julius?
we have some post-op, but
This were the post-op X-rays. We have another post-op CT, but intraoperative images I didn't include in this presentation. I'm sorry.
but he's now, I think this was like, he's more than 2 years at this point, Peter.
Yeah.
And he's actually done okay. One of the things I actually, Julius, is that he's, complained of, and again, he's sort of fused, but the main issue, and this is part of the reason why I included him, is what really bothers him is he's got pretty significant SI joint pain. Neurologically, he's probably the same or improved. And you can see there that one screw is kind of, and both sides actually hurt on him. And the question is, obviously I'm not enthusiastic about doing anything for this guy, but this is one of those patients where you're just like glad the guy got out of the hospital and didn't die. And so every time I see him, he fixates on his sacroiliac joints, and it's bilateral. It's not one versus the other, and you can obviously see that it fuses his spine, but he's just got this horrific pain. And Julius, I don't know if you can go through the SI joints at all, but this is one of those where you're like, do you go back in and maybe try to fuse his SI joint? I don't know what your thoughts are on that, but it just always seems to me like there's something with these cases. The patients always have something pop up.
Yeah, I mean, I think we'll touch upon that a little bit.
Yeah.
But I think there's a few ways to think about it. I think long term, the lucency due to rotational forces in the SI joint is not insignificant, and a lot of times, we see iliac fixation and we just assume it's SI pain. So I think, initially we were maybe underestimating it. Now I think we do have to make sure that things like, the L5S1 is completely healed and there's no persistent foraminal compression at the lower lumbar levels. So as long as those are ruled out, then I would do a typical workup for this patient, in diagnostic and confirmatory injections at SI, and to see how much I think the symptoms are related to the SI itself. I think in a case like this, you'd probably get some confirmation. There seems to be some irritation in those SI joints, and in these higher risk patients, I think it's difficult to achieve a fusion in the large SI joints with just percutaneous fixation. Although I have been successful, and that a lot of reports have been successful on that in higher risk patients, in the absence of open grafting. But I think that's something I would consider in a patient like this, where you don't want to do open surgery, as long as the iliac screws are not completely toggled and in good position, and L5-1 is fused, which I'm not sure about on the.
Yeah, I mean, I think on this case, I wasn't a rush to do anything for him. And I still, he's got a good posterolateral fusion at 5-1.
Great.
And so I was just, he was scheduled to get an SI joint injection and just kind of see how he does. But it's not one where, I'm rushing to do anything on him quite yet.
And any role in Rod, your practice, or Jens, for primary SI fusions for patients?
I think honestly, it's funny now that I think when you start looking for this, a lot of times, I remember when I started practice, you kind of blew these patients off, but now I really do believe it is a clinical syndrome. I just don't have as much experience. How about yourself?
Yeah, I've done it selectively. I think just because we can do something, doesn't mean that we should always do it.
Mm.
So, there's a few factors that I look at where I will consider doing a primary SI fusion. There's also obviously there's implants that can integrate or at the very least have surface technology, that we can use for our sacropelvic fixation, as well, which, arguably may minimize this, this problem down the road. So I think those are the two things I'm looking at and thinking about from a research perspective, is that, the role of the primary fusion and the type of sacral implants that we use. I don't think we have a definitive answer where this is what works every time. The other thing I'll touch upon in my talk is, we are, a lot of the deformity, consensus here is, more fixation points into the ilium, so for various individuals. I don't use 4 iliac screws on every patient like some other centers do. But some patients that are high risk, where you want to minimize rotation through the SI joint, like low osteotomy, 3-column osteotomies that are low in the spine, high frail patients, really large coronal or sagittal translational shifts. Those are patients I consider multiple points, because I think some of it's not just degeneration of the SI, and some of it's not just toggling of the one screw, but it's also the rotation that you see if you just have one point directly. It almost hinges that SI joint. They call it nutational forces, in the engineering world.
Yeah. Okay. We have a couple more cases, Peter. Brian Anderson, one of our fellows, has another interesting case. Brian.
Hey, good morning. Yeah, thanks for having me. I do have a quick case that I'm going to present. This is a 72-year-old female. She's had multiple falls over the last couple of years, and over the last couple of months, she's had progressive pain in her mid-back, numbness going down both legs and in both feet, and weakness on the left side more than the right. And now she's so unsteady and weak on her feet that she's using a wheelchair. She had 2 prior surgeries back in 2015 and 2016, a T4 to pelvis, and then a revision from 12 to 1. Her bowel and bladder is intact, but on exam, she's very weak in the lower extremities, 1 to 3 out of 5 in both legs. She has bilateral S1 radic, and her BMI is not bad. She's got a history of RA, IBS, hypertension, fibromyalgia, anxiety, depression. She lives independently with her husband, and who she relies upon a lot now, given her weakness, and she is retired. Here is an AP and a lateral Scoli film showing her construct, and this is right before her last fall. You can see that there is hardware complications down in the pelvis. That's pretty obvious. But the only other way for me to show you the fractured hardware was this tissue subtraction image on the right side. You can see she has both spanning rods are fractured right above that cross link. Here's a CT, lateral and axial, showing that she has a significant compression deformity at 12, right there. And she also has a fracture of her posterior lateral fusion mass at that level at 12.1, and the rods at that level. And then she has the hardware complications distally that I showed you in the previous scan. And this is just her thoracic scan, sagittal and axial, and no real complications up here. But again, you can see that 12.1 pseudo with the hardware complication. I'll just zoom through this. All right, so quick summary: 72-year-old, history of T4 to pelvis, multiple hardware complications. She's got this T12 burst with, I'm sorry, I didn't highlight it, but she's got T12L1 stenosis on this. This is actually a CT myelo here, and she's got complete contrast cutoff at that 12.1 level right here. if you can see that. Meant to highlight that before. She's got severe low back pain, weakness, and she's now wheelchair dependent. So this is a patient that we elected to take back to the operating room. So we took her back and we did a revision from T8 to pelvis. We removed the hardware. We did a decompression from specifically 12 to 1, but we revised everything down to 5. She got Smith Peets at 2 to 4 to help recorrect her, and then we reduced that kyphotic deformity at 12-1. Then we re-instrumented her with rod connectors and a quad rod construct, and then did a T8 to pelvis arthrodesis. And given the pelvic fixation complications, we did a direct fusion of the SI joint bilaterally with autoanallograft. And then otherwise, the surgery was uncomplicated. Here's her post-op CT. Immediately afterwards, you can see the correction at 12-1 and the improved sagittal balance. And then this is her a year post-op now. She's listing off to the right side, but you can see, and she's a little forward up top, but you can see that she's maintained her construct, and her exam is significantly improved. And so that's my last image.
So Peter, this is another case. If you can go back, Brian.
Sure.
This one where she actually came in, neurologically was, it's kind of like she came in, it's almost like an incomplete spinal cord injury. And where, again, it's tough because you could see she doesn't have great bone at all. And she had developed kind of that fracture, and then she broke her rods. And then the issue was, again, I think she was doomed to fail. And the initial surgeon that did this, I don't think, obviously she's got pretty significant coronal imbalance.
Yeah.
But I don't know what your thoughts are on these ones where, they come in kind of urgently and you kind of want to correct the deformity, but at the same time, I was a little nervous to do like a PSO or to put, try to shorten the spine in any way. I don't know what your thoughts are in terms of like trying to do these cases where, they have a deformity, but then they've got other issues going on.
Yeah, and I think there's three ways I look at this, and I agree with your line of thinking, Rod, entirely. So there's patients with really a sick neurologic issue, where their cord or their conus is at risk, and in those patients, oftentimes I'll do less. I don't shy away from big surgeries, obviously, but those particular patients, you're dealing with a focal issue. You can always come back and do more surgery and a better realignment as long as you discuss that with them. This patient also has the kind of third component of, that we're getting some winners today. These patients are not healthy. You're supporting your medical staff in Seattle, so I'm happy to see that. But so these are always difficult situations. Ideally, this patient, you were able to optimize the last patient. I was very impressed by that. And from a bone health perspective, also, I think that goes a long way. There's a lot of nice new options, that can help mitigate issues. So, I don't disagree with your approach, from a neurologic perspective. I think that being said, in the grand scheme of things, if this is a functional patient, certainly the initial failure and certainly any subsequent failure, I think is largely related to the inadequacy of the global correction, and the basal correction at the L4 to S1, I think is a little bit, inadequate. So
Yeah.
If this was a little bit healthier patient, then I think we'd really want to put this spine back in proper alignment, especially given that they failed once. And I do like your approach to the SI fusion in the setting of catastrophic failure at the lumbosacral junction. And the other thing is I like to bring, in these cases, 4 rods down to the level of S2, which I think at least on one side you did. So, oftentimes we'll see a lot of rods crossing even the lumbar junction, the lumbosacral junction, but you really have to bring them down below where those forces are that are the S2 heads are seeing.
And Brian, show the coronal. What would you do? Let's say if now, and again, she's doing okay, but obviously she's not balanced. What would you do if let's say she she doesn't want to have anything done at this point, but what if she said, look, Dr. Passias, I want you to fix I'm leaning over. What would you do to correct that coronal deformity?
Yeah. In my mind, this is a very straightforward asymmetric 3-column osteotomy. She has previous anterior fusions. She's going to heal that osteotomy very well. And it's really at the base of her spine. So I would probably do this at L5. And you don't have to achieve too much from a sagittal perspective. She's elderly, she's non-ambulatory predominantly, and her global is not as bad as her coronal. And she's also a little flat in the thoracic kyphosis. So if you get a major sagittal correction, you're going to have issues more proximal in the cervical spine. So I would do kind of a low type 3-column osteotomy at L5 asymmetrically, bring her back into position, and I would have 4 fixation points through the S2I. It looks like those are fused with screws. So so you already have the base for that.
So you would do an asymmetric PSO of L5?
Assuming physiologically it was worth her while and she was an ideal candidate. But that's how I would tackle this.
And then I think I remember, Brian, can you show that? I thought she fractured her hip or did something on that one side.
Yeah, you can see just the bottom
Does not have great
left
hips.
hip here. She's got a
Yeah.
trope nail from a hip fracture. Bottom left, right.
That was pre-op. Do we have a post-op just to see what the?
That's the post-op X-ray, and then I don't think that trope nail's on the subsequent imaging. Sorry, I didn't include that. Oh, here it is. There you go.
Yeah, we talked about adjusting the aggressiveness of our plan, in the setting of neurologic pressing issues. I'd be interested to hear from others. What other factors do you adjust your plan for? Is it just everyone gets the same correction? Do you base it on age? Do you base it on PI? Do you base it on function? I certainly increasingly do, but I think those are minor changes if we look at the differences in measurements. When we have such great, and that may apply in the sagittal plane in this patient, where they have kind of an upside down lumbar spine, and the lordosis is a little bit high, but this patient may be able to tolerate that in their age range and their physiologic age range. But when we have above certain thresholds, I think all those rules go out the window. And when we have greater than 4 centimeters of coronal translation, I think no matter what stage you are in life, no one's going to do well with that.
Well, and I don't know, Peter, like in our practice, we've there's we'll discuss some. I think there's a case coming up with, but PJK. I mean, there's so many complications that happen in these cases, and these are challenging cases in terms of sometimes even, and I think our group, like I've kind of gone away from doing PSOs. I try to stage my surgeries. We've tried everything we can to try to go away from doing sort of more acute corrections. Just because we had, again, in my experience, I had such a high complication rate with PSOs, nerve root injuries, and so I started doing a lot of lateral. So it's interesting to see how things have evolved. But obviously, with her, I think a PSO, is pretty I think that's the only way to really correct that coronal balance. But it's tough, you know, and especially I think, and I don't know how it is in Duke, but gosh, here it's like clinic is just full of people that have had fusions and, you know, failures, and, you know, their previous surgeon doesn't want to touch them, and, you know, and then you're sort of like, you know, if you operate on, we try to do surgery obviously as a last resort, but gosh, I mean, it seems like our clinics are getting, I don't know how it is at Duke, but it's like more and more patients are showing up with adjacent level problems, PJK, poor bone quality,
Yeah. Yeah, no,
you know?
full disclosure, I'm just getting started down here, but I've, you know,
Mhm.
talking to my colleagues, I definitely, that sentiment is echoed, and that's what we experienced in New York. You know, where we're getting, you know, very large numbers of revisions, you know, as I was discussing earlier with Jens. I think, you know, the cases we saw, you know, were well indicated in the sense that they had progressive neurologic deficit.
Mhm.
I think one of the difficult issues and the way I screen some of these patients in the clinic is, you know, based on their symptomatology. I think, you know, what is their main symptom? If it's not in the setting of progressive neurologic compromise, you know, then I'm more reticent to operate on a lot of these patients because, you know, some of them just will not do, they need a high risk procedure to have a good outcome, you know, but medically they won't tolerate that, you know, and I think, you know, that's the big question. And I've heard, you know, I've heard it said at a recent meeting by a mentor of mine that, you know, if you're an adult spinal deformity, you know, and I do adult NPs, but if you're an adult spinal deformity surgeon and you're not in a full clinic like the one you alluded to, you're not talking more patients out of surgery than you're indicating, then I think there's a problem.
Yeah. I do think we have another case. The other issue, Peter, and I think we'll probably talk about this more, but you know, it's you almost feel, and again, I know this is probably happening across the country, but there's you know, you almost there's this economic crisis also that's happening, and you know, these cases are such a tremendous burden, you know, financially for any system. And what we've kind of seen, and I don't want to say we've become the dumping ground, but it's like that people just don't want to take care of these patients.
Yeah.
And once you open the floodgates, it's like it's just endless number and I feel really bad for the patients, but it's like we can only take so much of these patients because we only have a limited number of surgeons, limited number of resources. It reminds me of my fellowship here in New Zealand, where you know we're trying to ration who gets surgery and who doesn't. And I think, you know, again, I mean, I think COVID kind of exasperated that, but I don't know how it's been for you guys, Peter, but it's just, it really concerns me because I feel like we don't have the resources to handle, you know, the volume of these patients that are showing up.
Yeah, I'm glad you brought that up, you know, Rod. I think that's something that on a lot of these meetings, you know, we'll show a bunch of x-rays, we'll talk about realignment techniques and idealistic goals, but we won't talk about, you know, the hospital system supporting these cases and the sustainability. And I think that's probably, of all the things we discussed, is the most pressing issue, you know, at hand. And, you know, I think from our perspective, you know, I think hopefully we can work to at least come up with some general consensus of, you know, surgical candidacy and surgical goals to really be able to have some degree of durability, you know, no matter what health economics ASD study you read, if you don't avoid a reoperation by 5 years, you're never going to reach cost utility goals. You know, so that is kind of, I think, target number one. And, you know, and then minimizing, you know, the operative burden, you know, which are other things we're working on institutionally and research wise. But, you know, I think we have to be a little bit more selective you know, with some of these cases as we just discussed. And I think we're going to be told what to do if we just are operating on all of these cases. You know, that last patient, if they did not have a neurologic issue, a neurologic emergency, and they were non-ambulatory, you know, what is the utility gained on operating on that patient? You know, they're not on the top of my priority list in the absence of a neurologic deficit in clinic, you know, and then it becomes a discussion with your institution. I mean, some of these institutions, it depends on how they're structured. You know, they're reimbursed for doing high risk cases. They're, you know, if you don't look at the immediate numbers and the bottom line is something they can sustain. Like a lot of institutions, though, will not be able to handle a high volume of these cases, and you have to kind of know, and those may be referred to, you know, specific centers of excellence. You know, because if you do these cases every week in your community hospital, they're just going to tell you right, you know, they can't sustain that. And I've had colleagues in Europe, even colleagues in the United States, where that's been the conversation with their admin. But I agree, that's priority number one to look at.
Well, and also too, the other thing is, you know, if you look at it, and I don't know how it was for you in New York, but you know, for us, you know, we you know, there's probably like really only 2 or 3 centers that do this, and then you know, we've got call and we've got all these other things, and it's already, you know, the systems are already strained as it is. And then again, between COVID and staff shortages and whatever, you know, has happened, inflation and all these other things, it seems like it's crazy to me that here you have, you know, look at insurance companies. United Healthcare is having their best several years, right? The device companies are doing okay. Pharmaceutical companies we're doing very well. And then here, you know, you have, I mean, I'm sure you've probably seen some, I mean, major health systems are going under. And it blows my mind that here we would do a huge surgery for someone like this, and then the reimbursement for the surgeon is like, you know, a couple $1,000.
Mm.
And then, you know, it just, to me, it's crazy. It's unimaginable that you could, you know, like Jens and I were talking about this, like my plumber charges more for coming, you know, to your house,
Yeah.
and doing stuff than what we get paid to get reimbursed. And then here, between, you know, the cost of care and everything, it just, to me, seems like there's an imbalance that's currently there.
Yeah, no, I think I mean, being honest, that's being brutally honest. And
Yeah.
that's it's again, it's not spoken about, you know,
Yeah.
in public venues too much, but you know, I think that's, you know, that's some of the role of our societies, you know, in terms of outreach, and PACs and things like that, where, I mean, there's just these absurdities that exist in healthcare, and they're becoming more disparate. And, you know, how you have nonprofits making record, you know, year after year, increasing profits, you know, from the insurance perspective, where every other element of healthcare is strained. You know, and you know, you mentioned, you know, from a system perspective, but I agree from a surgeon perspective, you know, even physically and mentally, you know, doing these cases every single day of your career, it's just not sustainable from a mental health and a physical health perspective, and especially if it's, you know, something, you know, where it's taking so much of your time out and it's reimbursed at those rates. So, I mean, I think that's something we need to come together really as a society. It's hard because we're interacting with our institutions, and we're, you know, and we're not directly interacting with our payers. But I mean, I just think I agree. I'm glad you said it. I think it's insane. It's really insane.
Yeah. So I think it looks like I think Amir and David had a case, and Jens, but maybe what we'll do, Peter, is I I think he might be in the OR. So if you don't mind, we'll go ahead and I'll we'll switch to hear your presentation, and then we might have some time for some discussion at the end. How's that, Peter?
That sounds great. And I just wanted
Great.
to, before we do
Yeah,
that,
so let me pipe in. So good discussions. And Dr. Randy Davis, it's always great to have you, Dr. Davis. Identified that our actual reimbursement has decreased 60% over the years. So that's a substantial thing. So huge privilege, and I wish I was there in person to introduce you and be with everybody. But fantastic to have Dr. Peter Passias here, a professor of neurosurgery and orthopedic surgery, and truly one of those incredible Renaissance people who's just done so much in his life already. Mechanical engineering, residency at Tufts, additional training at Harvard, combined fellowship, focused adults, deformity surgery, traumatic injury of spine. He also has a degree from MIT on spinal realignment, and he has several NIH grants from this. A very distinct career indeed. And further training then with the Hospital of Special Surgery on Weill Cornell, New York, Presbyterian Hospitals. And he did something that I've heard of before, but never knew anybody. He actually did a traveling fellowship at the Peking University Hospital, and I've heard of that place, doing nothing but atlantoaxial and occipital-cervical deformity. So that alone is just a fantastic exposure. And he knows of pediatric and adult spinal deformities like nobody else. And he's a very, very nice guy, moreover. He's over 500 publications, and he is the chair of the editorial board of the JNS Spine and deputy editor at Spine Journal. So an incredibly knowledgeable person. And as I said, an incredibly nice person. He's going to talk to us about lumbopelvic fixation and about finer points to have a good foundation in the general sense for spinal deformity surgery. So true pleasure to have you here. And sorry I had to talk to you without a tie on from Thailand, but this is very important to all of us to have you speak today. So our whole group is sitting there, about 8 of us here at GSC, and they're going to listen to your lecture on my phone. But thank you for joining us, Peter.
Thank you. Thank you so much for those really kind words, Jens. And again, Jens and Rod, this is my 4th time in Seattle Science, and this is always one of the highlights of the year. You guys just do tremendous work for our entire field, and I just want to thank you for that. So let me share my screen, and I'm sorry I can't be at GSJ this year due to my job change, but I look forward to it next year, and I'm certainly big hello to everyone in Thailand. Okay, can everyone see my screen okay?
Looks great.
Okay, great. So again, thank you for the introduction.
Yeah.
And we were given kind of the task of talking about some of the sacro-pelvic considerations in adult spinal deformity surgery. And I'd like to start off first by really acknowledging one of my mentors, Virginie Lafage. I've taken several of her ideas and some of her images for this talk. And also one of my research fellows going into neurosurgery, Ankita Das, and who helped out with the talk. Let's see. Okay, these are my disclosures, and I think they're listed online as well. So we'll start off with a little bit of a general outline, just go over some basic principles, which I know everyone on this call is aware of, but to review. And then we'll get into some of the sacro-pelvic fixation techniques, some of the common clinical scenarios that we have to deal with these types of instrumentation. And we'll talk about the impact of sacro-pelvic fixation on spinal biomechanics, and then on the SI joint. We'll go over some of my preferred contemporary techniques, and then we'll talk a little bit about future directions. So, by way of introduction, in terms of the importance of the pelvis in the spine's overall alignment, this cannot be overemphasized. We know that despite everything that we've achieved and we've learned over the last 2 decades in terms of spinal realignment, still about 0.25% of our adult spinal deformity patients remain significantly malaligned. And one of the thoughts is that this is in particularly related to our lack of incorporating adequately pelvic and lower extremity compensatory mechanisms into our corrections. We're all familiar with this formula. I reversed it a little bit to be a little bit more pelvic centric, where PT equals PI minus sacral slope. And we know that of these, the pelvis is really the most stable. It's not completely fixed, but it is a morphologic parameter. And the other two values, the sacral slope and the pelvic tilt are really what vary. We know that the sacral slope really has a linear relationship with PI, so a small PI, you have a small SS, and vice versa. And because the PI really dictates the slope of the sacrum, it dictates the lordosis. So patients with a large PI have an SI that's tilted and marked long lordosis with an LL within 10 degrees of PI. And so for the same lumbar lordosis, like you see in this particular individual and different PIs, you have very different global alignment. And we know that the pelvis is really one of the primary mechanisms we compensate for spinal malalignment. And this is quantified with pelvic retroversion, which is a positional parameter with mean population norm values of around 13. This is a slide representing three broad variations in pelvic tilt. You can see on the far right, that's an extreme pelvic retroversion with a PT of around 53. So in terms of the compensatory mechanisms of the pelvis, how does it work? Essentially, what the pelvis is doing when it's retroverting is bringing the spine over the pelvis to achieve somewhat of a global lordosis relative to the feet. And this is more able to be achieved in large PI patients. Some of the limitations include that this requires hip extension, which can compromise walking. And not all patients use this mechanism, which we'll get into, especially patients with small PI and hip pathology. And horizontalization of the sacrum really is the maximum limit of this. We know that it's just part of a larger puzzle. So patients with the same thoracic kyphosis and lumbar lordosis, but differences in pelvic tilt can have very different clinical scenarios, as you see here. What muscular factors influence pelvic tilt? Well, the surrounding muscle envelope in the region, the hip flexors, the back extensors, as well as the abdominal wall muscles and gluteal muscles certainly influence this, which is some of the ideology behind prehabilitation. And but ultimately, as malalignment gets more severe and patient exhaustion occurs, we have to recruit other mechanisms of compensation. This includes hip extension, knee flexion, ankle dorsiflexion, and thoracic and cervical changes. How does the lower extremity compensation work? Essentially, we're dealing with cranial and horizontal shifts to accommodate the forward gravitational pull. And these are three extremes, the one on the right representing the end stage of compensation, including the lower extremities. How does knee flexion work? In particular, it basically permits additional pelvic compensation for the same degree of hip extension. So it increases the amount of pelvic retroversion we can achieve. Why is it important for us to understand compensation? Well, certainly it's directly related to energy consumption and thereby related to functional outcomes and disability. It helps us evaluate the true deformity when we're correcting these patients and plan appropriately. And it alerts us to potential additional pathologies such as neurodegenerative conditions. And ultimately, the main goal is really it allows us to evaluate the outcomes of our corrective surgery. So oftentimes we're dealing with these complex situations, such as this patient who has an adequate lumbar lordosis, but a really high pelvic tilt, which has been classified as Russell false type 2. And some of the drivers of this range from looking for hip pathologies, deformities that are really driven by spinal stenosis and neurogenic claudications and not true deformities, and sarcopenia-driven deformities as well are the three main contributors to those types of cases. We've gotten a lot more sophisticated in how we define pelvic tilt. Now we have age-adjusted parameters, we have PI, relative PI, adjusted parameters, functional parameters based on body position. And ultimately, we really know that it's not only the third most important driver of patient disability, but it also is a major driver of poor outcomes. Again, being present, what we refer to as pelvic non-responders in about 25% of patients. And we looked at our group and we found that about 80% of patients, this was directly related to inadequate lumbar realignment. So we're going to shift gears and talk about some pelvic fixation techniques. First of all, we're going to go over the historical basis for this. Why are we doing pelvic fixation? Why does it even matter, as we discussed in the case presentations? Oh, one of the first reasons is to protect the lumbosacral junction to prevent L5S1 non-unions. I think this is the best synopsis in the literature by Cavagnero and JNS. Again, note my disclosure in 2022, where they looked at 9 studies with almost 800 patients, and they broke it down into 3 common clinical questions. The first question was comparing pelvic fixation versus those without pelvic fixation, included 5 studies. They found that the mean fusion rate at L5S1 was 12% in patients with pelvic fixation versus almost a significant, almost 3-fold increase in relative risk of patients without pelvic fixation. So clearly it makes a difference. How about, and this is not just a radiographic change, by the way. If we follow these patients out to 5 years, like Park did, about 15% of these will have lumbosacral rod fractures, speaking to the durability of our corrections. Well, you might say, well, does it matter if the inner body is an A-lif or a T-lif at L5S1? Because that was the second question that they looked at, 4 retrospective studies, 243 patients, and they actually found no protective or counterprotective effect based on technique with a relative risk of 1.03. And I think some of this had to do with the short follow-up that was included in a lot of these studies. Most of them are only 2 to 3 year follow-up, but also a certain institution had a fair amount of representation, and you can see the milligrams of the potency of BMP that was used at the lumbosacral junction, 20 milligrams in the long fusion group without interbody. So arguably that impacted that, relative to the A-lif cohort. So talking about, does it depend on the type of interbody? We know that in most surgeons' hands, T-lif really will not achieve the same degree of lower doses as A-lifs. So there are exceptions to that, certainly. We know that the immediate stress and strain on the rod in most degrees of freedom, so 5 out of the 6 degrees of freedom that we typically study, are dramatically increased in the immediate postoperative setting for a T-lif. So it's really critical that we achieve a successful fusion in those cases. And the majority of the literature is in support of the fact that overall, A-lifts have higher fusion, less rod fractures at the lumbosacral junction in the setting of ASD. Now, like anything else in spine, there's always have a difference of opinion. You can find articles like these by Kim and Jiang, which show that there's no difference, but I'm speaking to the majority of the published literature. It's also important to note that even A-lifts can fail. I've certainly seen this in my practice on occasion. About 15% of patients in this 5-year study by Park had a non-union at L5S1 despite a well-performed A-lif. The second reason we consider lumbopelvic fixation is really to protect and to lock in our realignment. Inoki published a very elegant article looking at lumbosacral alignment based on the pelvic fixation, and they found that if you excluded pelvic fixation, you're subjecting the patients in adult spinal deformity to inferior sagittal, regional, as well as global alignment at the 5-year mark, and specifically inferior coronal control and mechanical complications. And this has been confirmed in meta-analyses by Hahn and others. And then we looked at our particular experience here in terms of whether the pelvic tilt was normalized, and we found that this was related to complication rate, implant failure, rod breakage, and pseudoarthrosis, again, limiting the durability. And this is a clinical case of mine where the patient, this is 5-year follow-up, and they maintained their sagittal and coronal correction with really stable fixation at the lumbosacral junction and into the pelvis. And this is a patient of mine with less stable fixation who at 5 years lost a little bit of their coronal correction despite maintaining their sagittal correction. Why does this occur? And we discussed this a little bit in the case presentation. There's this concept of nutational forces, basically pivoting around the SI joint relative to a fixed sacrum. And patients without pelvic fixation end up with a smaller but significant diminishment in pelvic incidence, which I know is counterintuitive relative to classical teaching, but this can result in lack of durability and maintenance of correction long-term, as you can see in that graphic depiction. Other more obvious reasons include iliac screw loosening and migration, as we saw in the cases, which can cause more immediate impact on the maintenance of our corrections. The third reason is really to prevent stress shielding. Stress shielding is defined as inefficient stress transfer to the host bone, and where the stress is really only transferred to the surface of that bone. And essentially, our orthopedic surgeon colleagues deal with this on a daily basis, as you can see the osteolysis that's occurred in the acetabulum and the trochanteric region on this radiograph. And this, from our perspective, the concern here is insufficiency fractures, which anyone who's done enough spinal deformity will see these in their practice. In the general population, this can occur in about 2% of the population. This is a particular case after even a laminectomy this occurred. So it's a little bit of bad luck. But in adult spinal deformity, we see it in up to 15% of patients at up to 3 years out. So not an insignificant rate. Some of the risk factors include osteoporosis, lumbosacral arthrodesis, the greater than 3 levels, or more importantly, greater than 10 levels is another marker for increased risk. Patients with a high PI and those with inadequate corrections. And these come in all shapes and forms. And it's beyond the scope of this talk to go over all these. And my colleague Tom Buell has done a good job at coming up with algorithms of treatment, which ones could be managed non-operatively, which ones could be managed non-operatively. But one point I will make is that, if having sacro-pelvic fixation does not obviate the occurrence of these, but when it does occur in this setting, it's a lot less likely to be translated, kyphotic, resulting in neurologic compromise and requiring a reoperation. So there is a bit of a prophylactic measure with these when using sacro-pelvic fixation, not just in terms of treatment. We've come a long way in sacro-pelvic fixation. We've gone from monaxial sacroalar screws, as well as hooks, which failed almost half the time, in the 80s. We then moved on, to Galveston techniques, which loosened and had major issues with prominence, and we then started to learn how to properly place S1 screws angulated medially, as well as in the opposite direction, reverse anatomic, essentially to maximize length and to really capture also the cortical bone of the S1 end plate, as well as the anterior sacral promontory, as you can see depicted here in this patient with transitional anatomy. In the 90s, we started using traditional iliac screws, which allowed for better interdigitation of the ilium, and the first really implant to provide some control of the pelvis. And in contemporary times, most of us have switched to S2AI techniques, which, although it has a narrow safe zone, and these are the anatomic feasibility studies that came out of Hopkins, this allows for greater capture of that cortical bone in the distal portion of the teardrop. And if you can get these screws kind of beyond the 90-degree mark in terms of millimeters, the length in most patients, and enter the hip axis, this really has a strong biomechanical perspective. Not to mention improved issues related to prominence, as most of these are about 15 millimeters deeper than the PSIS. And also, a lot of us do revision cases, as you saw in these case presentations. And a lot of these cases have had previous either traditional iliacs or harvesting of the iliac crest, and this technique is usually not obviated by this occurrence. What about failures of our sacro-pelvic fixation? Bob Eastlack looked at this out of the ISSG data and found an overall rate of about 23%. They categorized them into pseudarthrosis, screw rod fracture, and screw loosening. And about 5% of cases were immediate failures requiring, basically catastrophic failures requiring immediate attention. And these are 2 cases of those with an L5, S1, and S1 fracture, respectively, out of that group. And when we looked at our series of these, we found that about 80% of these patients were pelvic non-responders. So along the lines of the initial introduction of this talk. Let's go over some common clinical scenarios that we encounter on a day-to-day basis in the clinic. So upon cranial extension of previously successful fused L5-S1 segment, is pelvic fixation necessary? Well, the answer is yes, if you're going to be treating a significant deformity. And the reason why that is there's stress shielding in the proximal sacrum, and this can result in resorption. And I think the literature is pretty clear on that. Question 2, how many fusion levels are required? Does it require pelvic fixation? Literature is not as robust on this. I think one of the best articles is a biomechanical study by Newman and Cabej, looking at this changes in the biomechanical field when the implants go above L3. So most of us use L2 as a hard threshold. So question number 3, S2I versus traditional iliac, which is a common source of debate. And a lot of this depends on our training and is patient specific. Certainly iliac screws are tried and true. But the issues with prominence is not insignificant in the literature, estimated up to 34%. S2AI screws really are protective of implant failure reoperation. They have lower rates of SSIs and wound dehiscence in the literature. And this interesting article by Ishida showed that they actually significantly decreased pelvic incidence compared to traditional iliac screws, resulted in a lower reoperation rate. It hasn't been broadly repeated in the literature, but I think it's a very interesting finding, and it reached high levels of significance. This has been confirmed by meta-analysis and by Hassan et al. More contemporary surgeons have tried subcrestal techniques. Basically, you're not violating the SI joint, but you're starting a little bit lower in the PSIS. And there's some small series with promising results on this, as you can see here by Liu et al. So question number 4, how many screws are necessary? So I'm going to avoid the unilateral versus bilateral debate. I think for significant deformity, a lot of us, definitely would not entertain unilateral fixation. But when do we have to go more than that, as you saw in that last case? So some of the factors I consider are the symptomatology in the SI joint, the frailty and complex with sarcopenia and osteoporosis of the patient, the anticipated degree of sagittal correction, the degree of translation in the coronal plane, and if it requires a 3-column osteotomy in a revision case or fixed rigid curve, how low is that going to be performed? It's going to be performed L5-S1, and I typically will go more than 2 points of fixation to the ilium. We also increasingly use iliac fixation to help with our realignment, as popularized by Lenke with the kickstand technique. And these are 2 cases of mine. This patient had a lumbosacral hemivertebra, very rigid deformity, a very muscular individual, really hard time getting that curve over, and the kickstand really helped on this patient. And this is another patient, a little bit older, with more of a collapse at the thoracolumbar junction, and we were able to achieve optimal realignment in the coronal plane using that technique. What about SI pain? Well, we know that this is a real issue. About 30% of patients have worsening or new onset SI pain after surgery. We talked a little bit in the discussion about the role of primary fusion. Certainly, I wouldn't advocate this based on the 6 studies that exist in the literature. And these are studies that are predominantly industry supported, but I think it's something that it should be looked at, particularly for cases that were presented earlier in this session. So what do? There's a preference for S2AI screws in all patients with a UIV of L3 or above, or any significant deformity, even if it's focal. In severely osteoporotic, frail, large corrections, low 3-column osteotomies, or significant coronal malalignment, I use 4 fixation points into the sacrum, usually for S2AI, except if it's coronal, where I add a kickstand. And if there's more than 3 out of 5 SI provocative tests and it's confirmed with a diagnostic injection, I will do a concurrent primary SI fusion. And this is a case of mine. The patient's actually 83, but independent, and patient had a low 3-column osteotomy and a primary SI fusion in addition to fixation points in the SI2 direction. What are some of our future directions and conclusions? Well, there's so much to handle here. We have all these competing alignment concepts, physiologic, comorbidity perspectives. How do we put these all together in a busy clinic, to Rod's point? And it's very hard. It's something you don't have a lot of time to think about these cases before coming up with a plan. You have a little bit more time in the week preceding the surgery, but it's something that I think AI may help us make some of these decisions in the future. There's a lot of centers that are looking at that. So in conclusion, don't neglect the base of the spine. It's really critical to our long-term success, and customize and confirm your alignment goals and techniques really to your patient's individual needs. And I'd like to thank Jens, Rod, and the Seattle Science Foundation again for their gracious invitation.
That was great, Peter. Can you go back to there was that one case, the two last cases that you showed with the kickstand? How
Yeah.
much, Peter, on your cases, are you using navigation or just in terms of pre-planning, and or any robotics? Yeah, I just wanted to see that. Yeah, that one right there, Peter.
Yeah, so great question. Yeah, I definitely have started using robotics and navigation and surgical planning tools. I think there's a lot more we can do with robotics in spinal deformities. I think robotics works most seamlessly in cases that don't have a large degree of deformity, which is somewhat counterintuitive. So it works the best in the cases perhaps you need it the least. But the algorithms have gotten dramatically improved and over the last several years, and that's it's very exciting times in robotic applications in spine surgery. So especially for pelvic fixation, like a case like this, or a case where you have 4 fixation points into the S2AI area, I find robotic planning and navigation to be very helpful because it's a small space for a lot of hardware. So
So in particular, Peter, on this case, you put in there, that's what I wanted to talk about. You said stage with robotic assistance. So tell me what you did in terms of the planning.
Oh, okay. Yeah. So in this particular case, the robotics were used for the pelvic fixation.
Got it.
And I also used it for the kickstand screw. And that was pretty much the utilization. The stage portion, the hemivertebral resection, I don't know if you could see on the previous lateral, but I did part of the resection actually anteriorly on this case.
Okay. Got it.
I'll show it.
And when you did you went anterior first?
Yes. Yeah, I freed up we discussed this case. I remember at conference, there was some debate. I've done these cases all posterior as well, and I know there's definitely achievable. I thought it was something that was very low and where it was something that was going to be very difficult to bring him over. So he was a pretty healthy guy, and I thought he could tolerate a fair amount of surgery. So I also wanted to reassess what I achieved and rescan him after the initial stage. So I use that as an opportunity. And most of these I will do all posterior, but in this particular case that I showed, I did an anterior release followed by the unilateral pedicle resection and completion of the hemivertebral resection.
Great. And then at what point, Peter, I've not used a lot of the kickstand. Tell me how you utilize that in a case like this. What's your sequence of like reduction, rod placement, and then how do you get the kickstand set up?
Sure. So typically, obviously you place it on the side of the translational shift, and it's really a distraction for. So some people will distract directly on the screw. I don't like to stress the screws to that extent, especially in short constructs where it's close to the UIV. So I'll put a connector, and then I'll just use typical distraction techniques. But often the other thing I do simultaneously is I'll have either my other hand or my assistant, putting translational forces while I'm distracting through the kickstand. The one thing I will say is, though, this will help achieve your translational alignment. Especially in the second case that I showed, where it's a more flexible deformity, and in that case, like independent of really a lot of work. But this case required a lot of bony resection, and this just kind of fine-tuned that. But I couldn't lift those lower segments out of the pelvis and translate them to the concavity, without that technique.
And then Peter, so then, like on this case, you'd put it on not on the concavity, but on the convexity.
Yeah, I put it on the side of the the side where you're translated towards, because
Got it.
you want to correct. This is correcting not the rotation. This is correcting the translation.
Okay.
And I think there are other ways to do that. I don't think this is the only way to tackle problems, but I think this what's helped me in a case like this is it's brought my translation from, let's say, 2.5 to less than 1. So it's kind of fine-tuning your correction, and it's also providing elevation of those lower lumbar nerve roots by distracting that spine out of the pelvis. So I think it's a little bit neuroprotective, and I think it's also more for the durability, if you can really get closer to that optimal coronal alignment. Because if these patients live long enough and they have enough forces, eventually their muscles are going to fatigue, their bones are going to weaken, and there'll be a natural pull towards the side that they're shifted. And from a basic mechanical perspective, the more you could minimize that force, I think the better chance they have of resisting.
And then one last technical thing, Peter, on like a case like this. So what's the sequence of the rods? Do you distract on the concavity, then compress on the convexity, and then put the kickstand in to push it over at the very end?
Good question. So if you look at this case, the predominant concavity is kind of L1 to L4. And if you distract on that, you're going to make your problem worse, obviously. So I do distract on the concavity, but I distract on the fractional curve first. So if you look at the base of that, so after the first stage and after my releases on the second stage, those lower segments were completely free, and I distracted based on my S2AI screws, my S1 screws, and I built that up. And then my last step was the kickstand to really help with the fine tuning of the translation.
Okay. Got it. And then going to the second case, this one, and then I think you did another kickstand.
Yeah, this is a kickstand. Here's the post-op.
Yeah, I was just looking at. So here, and in this case, and so are you putting it? I'm just trying to see the trajectory of the screw. So you're putting it sort of. How do you not avoid? So you're trying to aim it down.
Yeah, I think I understand where you're going. So it's in a different direction than a traditional iliac screw, where you're trying to stabilize the pelvis, get the longest screw possible. In my mind, and sometimes I will put it in that direction. In my mind, it's a little bit easier to distract vertically if I put it just kind of in line, directly from the PSIS. And I do use nav robotics to help me with that, to keep it safe. And typically, I don't think I need much more than this in a case like that. But if I were doing traditional iliac, I obviously would not put it in that trajectory.
Right. Okay. And then the same sequence here too, Peter.
I think, yeah, the same, pretty much the same sequence here, with the exception of this patient was a little older, and they didn't have perfect proportional alignment, but I opted not to do a 3-column osteotomy on this patient. I thought it was acceptable, and really their driver of their symptom was the thoracolumbar, collapse, essentially.
Yeah.
So I just left the bottom as is, and I had a really good base. I think what I did here was I put I reduced the rod and I did cantilever simultaneous with distraction on the. So I did this one simultaneous.
Got it. And then you did single position with the whole construct. That's really impressive. Geez. You got great realignment.
Yeah, this one it turned out to be pretty flexible.
Yeah.
After some basic releases, and whether or not the laterals helped, I think they did to some
Mhm.
extent. But I think you could also achieve this with an all posterior, but I think it kind of helped me with this level out that L3 area.
Yeah. That's a pretty significant correction. Geez, that's a great correction.
You can see
And
how.
And what's the are you using 6.0? What's your preference on rods right now, Peter? Do you use titanium or cobalt chrome?
Yeah, good question. So there's a lot of rod options now, and I think it's a whole discussion in and of itself. There's
Yeah.
customized, there's different grades of cobalt, different grades of titanium. There's other elements that we have now. Some of the 4 or 5 rods, come in the mirror combination of elements, which are equivalent to some of the higher grades of cobalt. So that's interesting to me, and I look forward to studying those as well. Historically, so initially I started off using cobalt in everyone and really going stiff, and then I've evolved. So I think in some of these osteoporotic patients, I've had a lot of issues with cobalt, with pull out. So what I'll do is sometimes I'll do my primary rod even titanium, and if I feel like they need some supplemental fixation, but that's not going to stress my screws, I'll put a third rod that's cobalt. But some of these really osteoporotic patients, I'm not using any more cobalt as my primary reduction rod. In younger patients, like that first patient I saw who really needs a lot of force to get that correction, those are all cobalt.
Great. Well, we really appreciate the terrific talk you gave. It's really incredible what the amount of work that's been done in this area, especially in the sacrum and the pelvis. As a neurosurgeon, Peter, like for me, this was always like this black box, it's really a credit to the orthopedic surgeons and guys like yourself who've really pushed the envelope. We really have learned a lot from people like you. It's always great to see you, and we're excited that you're at Duke now. That doesn't mean that you can't come to Seattle anymore. In fact, it's closer. So
What happened?
Hey, and a final goodbye here from Bangkok.
Yeah, thanks so much.
Everybody around. 1
I
second.
look forward to seeing you soon, and safe travels, Jen.
Pass the phone around.
Rod, you take care. Yeah.
okay.
Who's that? Who's that? How's it going, Dr.
Bye. Hey, how's it going?
Hi, Dr. O.
How are you
Nice to
guys
meet you
doing?
again. Hi. I think there are some other people on the Very good.
Hey,
How's it
Cliff,
going?
how you doing, buddy?
Great talk. We're here at Global Spine. Doing well,
Nice.
Dr. Scullion. Dr. Carson.
Awesome.
Hi.
Centralized.
Hey, guys.
Say hi.
Ronan.
Ronan, hey, buddy.
Dr.
How are you
O.
doing? Good to see you, Ronan.
Good. How you
Looking
doing?
good.
Yeah, you too, man.
Yeah, that's awesome.
Good times.
You guys, you missed conference, Ronan.
I don't. I watch all of them.
Yeah,
Thank you for including us. That was a wonderful talk, Dr. Passias. And thanks for moderating, Rod. You look great.
yeah, you bet. Love the
All right,
shirt.
we'll talk
guys.
shortly, okay, man?
Okay, sounds good.
Okay,
Take care, guys.
Bye-bye.
Okay,
Thank you.
bye.